So LASIK remains one of the most common corneal refractive surgeries that is currently performed, and fortunately the complication rate is quite low. But complications do occur. The published complication rate of femtosecond LASIK flaps is 0.37%, and for the sake of time, I'll just be talking about intraoperative flap complications and how to manage them. These complications include incomplete and torn flaps, decentered flaps, suction loss, and anterior chamber bubbles. So let's start with the incomplete or torn flap. Risk factors for this are when the femtosecond laser cannot photodisrupt the corneal stroma in an abnormal area of adherence of the intended interface. Risk factors include ocular rosacea, corneal scarring, thin flaps, and dense opaque bubble layers. If we detect the incomplete flap before lifting, such as in the case of vertical gas breakthrough, we can sometimes manage them and complete the refractive procedure. We do this by avoiding the standard superior to inferior sweep and lift the flap around the defect to prevent the flap tearing using a Cybele flap lifter and a retreatment spatula. So here is an example of a torn flap, and the surgeon does not recognize an area of vertical gas breakthrough in the periphery. So they continue with a superior to inferior sweep as such, and when they get to this area, you can see that there's a little resistance through this OBL, and what happens is in the area of the vertical gas breakthrough, there is a torn flap because there's an area of adherence. So one way to manage this is if you identify this first, you can lift the flap around the vertical gas breakthrough and at the very end try to sort of dissect this with the sharper end of the flap lifter. So to prevent an incomplete flap, if the scars are anterior, such as from old foreign body scars, you may increase the flap thickness to have a flap interface posterior to the level of scarring. If the scars are mild to moderate, you can adjust the femtosecond laser energy or use a mechanical microkeratome. And if there are severe corneal scars, do not use the femtosecond laser. How about decentered flaps? Well, one of the nice advantages of using a femtosecond laser is you can actually see where the flap's being cut before actually proceeding with the laser. So here you can see that clearly there's a decentered pupil. In these cases, do not continue with the laser treatment, just stop and redock. You can use a surgical marking pen to mark the center of the pupil to help you with alignment. Decentered flaps occurred from decentered suction rings, eccentric pupils, if there's parallax error, if there's pseudosuction and suction ring slippage during the treatment. Some laser platforms have centration software, but the disadvantages are that it does shrink the flap diameters on some laser platforms, such as the Intralays, and is not available in other laser platforms, such as the Visumax. How about suction loss? Suction loss is probably one of the most common reasons for interrupted femtosecond LASIK. This can occur here when you see a little pseudosuction, and depending on where the suction loss occurs, you may be able to continue the treatment and complete the refractive procedure. Mastering the fundamentals of docking is important to avoid suction breaks. Make sure that you have complete suction and not pseudosuction. And some manufacturers of the femtosecond lasers recommend that when a suction break occurs, the procedure should be reattempted immediately while the bubbles in the interface are still present. So recentering after a suction break, I like to make sure that your suction ring tries to find the same place of the initial suction. What to do if the suction break occurs during the Raster pattern. Again, we said perform the next steps immediately to try to find the same plane where the gas bubbles exist. If you have a interlace laser, you can select cancel on the menu box. Use the same applanation cone to reestablish the same lamellar cut depth, but replace the suction ring. And you can adjust the parameters by turning the pocket or channel off in order to minimize the energy delivered on the second pass. And once docked, you can use the arrow buttons to align the center of the previous treatment so that you're within the previous area of lamellar cut. What to do if the suction break occurs during the raster. If suction loss occurs more than 3 attempts, you can abort the procedure and ask the patient to return either the following day, week, or month. And when I have the patients return at a later date, I use a different depth, at least 40 microns away from the original lamellar pass, so that I don't get chatter or breakthrough into the original lamellar pass. You can always consider surface ablation as an option as well. What do you do when suction break occurs during the side cut? You can select side cut only if you have an interlace. If you may consider to decrease the flap diameter by 0.5 millimeters so that your side cut is well inside the lamellar cut. And if you have a laser platform such as the FS200 that doesn't have a side cut only software, you can adjust the settings to reduce the lamellar cut energy and increase the line spot separation so that you're essentially delivering no energy in the lamellar pass and just doing the regular energy settings for the side cut. How about anterior chamber bubbles? This is thought to occur when the channel or pocket is delivered close to the limbus, or the entire cut is delivered close to the limbus in a case of a very small white to white or small corneal diameter. In some laser platforms, excimer laser platforms, you can't proceed without tracking. So what do you do if the AC bubbles interfere with your pupil tracking? You can wait for the bubbles to resolve, but this can take several hours. You can turn off the tracker if your excimer laser platform allows you to, but if you must use the tracker, you can have the patient move their eyes side to side or tap on the eye to try to get these small bubbles to coalesce into one single bubble, and then you can turn down your illumination light so you can start to get the diameter of the pupil larger than the diameter of the gas bubble. You can use mydriatics, but be aware that sometimes as the pupil dilates, the center of the pupil will change. So when I use mydriatics, I try to use a gentle mydriatic and be ready to fire the excimer laser as soon as the pupil gets large enough that I can track. I do not recommend AC taps to remove AC bubbles. So in summary, intraoperative LASIK complications are uncommon, and often these can be managed effectively in the same operative session to allow for completion of the refractive procedure. I'd like to acknowledge Chris Blanton, who provided a lot of these videos, and make a plug for his course on femtosecond laser complications on Monday. Thank you very much.